known as diabetes mellitus, which we normally refer to as diabetes. The reason for differentiating is that there is another medical condition that is also diabetes, but that one is known as diabetes insipidus, which also causes the same problem with passing urine. So you need to differentiate between the diabetes insipidus and diabetes mellitus. So the one we're talking about, the one that people talk about as blood sugar problem, is known as diabetes mellitus, not insipidus. So subsequently, I will be referring to it as diabetes without adding the mellitus. So now we are clear that what I'm discussing is diabetes mellitus, not diabetes insipidus. So we will need to start by understanding what that disease is. What is diabetes? In layman's term, is a blood sugar problem. Blood sugar problem. So diabetes is a kind of a chronic means long-term medical disorder that affects blood glucose and is due to problem of a chemical or hormone known as insulin. So in essence, diabetes is a problem of insulin. I will explain. There is an organ behind the stomach known as pancreas. So this organ produces different chemicals and enzymes. And one of the chemicals or hormones that the pancreas produces is known as insulin, and is the beta cells of the pancreas that produce this insulin. We call it islet of Langerhans that produce this insulin. So the insulin is a chemical, a hormone, produced by the beta cells of the pancreas. What is the function of this insulin? Normally, when you eat food, especially your carbohydrate, maybe eat your yam or your white rice or your bread, is digested through your digestive system, and then the end product of that digestion is glucose. So this glucose is what the body basically needs for energy. But the problem is that the body is not able to use glucose directly. So the cells cannot go into the blood, take glucose, and start using and converting it to energy. The body requires this chemical known as insulin to move the glucose into the cells so that the cells can use it and convert it to energy. So you need the insulin to move the end product of this digestion, which is glucose, into the cells for use. And then the excess of it, of you didn't use, maybe you ate a lot and the glucose is moved into the liver and stored there, like storage, in the form of glycogen. So normally what happens is that when you eat and your food is digested and glucose is produced, and then the blood, and is in the blood, the pancreas senses that you got glucose in your blood, and it will produce insulin. And it's this insulin that will facilitate the movement of the glucose into the cells of the body to be used for energy, and also to move it to the liver to be stored as glycogen. In situations where you're starving, or there's a reason for you to lack glucose, that stored glycogen in the liver can be reconverted to glucose by another enzyme produced by the pancreas known as glucagon. This is called glycogenolysis. So essentially, diabetes deals with the sugar and the hormone insulin. So diabetes is a very common condition worldwide. It affects millions and millions of people. Only last year, about 4.1 million people died from diabetes and its complications. So it's a very important disease, and it affects man, woman, child, old, adult, and it affects black, white, even though it's commoner in Black Africa, Asian, and things like that. It's commoner in those places, but it occurs everywhere. So diabetes is a major issue worldwide. It so that is what diabetes is: a chronic disorder which is due to problem with insulin. And insulin is a chemical or a hormone produced by the beta cells of pancreas. And pancreas is an organ just behind your stomach. Stomach is not your GI in your tummy. That when you eat food, your food enters there. So that's how diabetes occurs. So that is the division of diabetes, which I mean diabetes mellitus. So you want to know what are the symptoms of this disease. What symptoms would you be having? And then a doctor or anybody would suspect that you may be suffering from diabetes. What are those symptoms? The most common symptoms are what we call osmotic symptoms. In biology, you must have done osmosis. So due to the build-up of sugar in your blood, these symptoms happen. One of them is what we call polyuria. Polyuria is passing volume of urine frequently, going to wee frequently. It's different from frequency of micturition that we see in urinary tract infection, in the sense that in UTI the volume of urine is normally small, while in diabetes the volume is quite a lot. So we call it polyuria. You can also have what we call nocturia, means you wake up at night to wee a lot. And because of this, you may feel thirsty a lot and have what we call polydipsia, where you have to drink a lot because you're so thirsty. It's called polydipsia. And some people, because of all these symptoms, they get hungry a lot and they suffer from what we call polyphagia, that they eat a lot. Despite eating a lot, many of them lose weight when they have not intentionally wanted to lose weight. So weight loss is one of the possible symptoms. Apart from these osmotic symptoms I've mentioned, polydipsia, polyuria, polyphagia, weight loss, you can also have other symptoms like blurred vision. Sometimes you may have a lot of yeast infection, especially in women. And then you may have sores that don't heal. So the symptoms you may have may depend on whether you have complications or you don't have complications yet. So I would explain the complications you can have from diabetes and the symptoms of these complications. So at any point in time, you may present with the complications or just osmotic symptoms or these other symptoms. So these are the common symptoms of diabetes: osmotic symptoms, polyuria, nocturia, polydipsia, polyphagia, weight loss, itchy skin, blood vision, So having talked about the symptoms, I would like to talk about what are the complications you can have from diabetes before I talk about types of diabetes and all sorts of other things. But let me just quickly talk about complication. So if your diabetes is not properly treated or managed, you may develop complications. Complications are after effect or from a disease condition. So in diabetes, we have what we call acute complications, which means immediate complications that can happen suddenly. And then you have what we call long-term complications that can happen years and years and years of suffering from diabetes. So I will talk about the long-term complications first. So this can happen 10, 20 years after having been diagnosed with diabetes. One of them is problem with your eyes that we call diabetic retinopathy. The back of your eyes may damage and it can lead to blindness. So it is advisable that if you're diabetic, that you visit your ophthalmologist to have back of your eye snapped, you have pictures, and so that they can assess it and see whether there are changes in your eyes. Because if you develop those retinopathy and they are diagnosed on time, it can be treated and you'll be fine. But if it's not diagnosed on time and you leave it, it may lead to that blindness. There are also some other eye complications of diabetes, like cataract, that white covering of your lens, or you may even have glaucoma, which is increased pressure in your eyes. Some of these things can happen from diabetes. This is the eye complication. We also have the kidney complication, which we refer to as diabetic nephropathy, in which your kidney is affected and is damaged until you develop chronic kidney disease. And if it's not properly managed, it may lead to kidney failure and obviously death. So normally, have diabetes, you are advised to check for if you have a kidney problem. We normally check that by taking your urine, early morning urine especially early morning urine, and check what we call albumin creatinine ratio. You know, albumin creatinine ratio. So you can use that to have an idea if your kidney is damaging. You also check your electrolytes and urea and creatinine. So at least you should try and do that at least once a year to know if you're developing kidney problems. So that is called diabetic nephropathy. Because diabetes damages the nerves and vessels, it can also cause what we call diabetic neuropathy, in which case the nerves in your legs, especially legs and hands, may have been damaged that you start your leg may be painful, you may feel numb your leg, or if you put your feet on the ground, you don't feel that your feet on the ground. Sometimes you feel like somebody walking on a foam. That's diabetic neuropathy. And also diabetes, because I said it damages nerve and vessels, it puts you at risk of developing stroke. It also puts you at risk of developing heart attack, what we call myocardial infarction. And also, there's something we call diabetic foot ulcer. So with diabetes, healing is poor. There's some people that have this long-term ulcer that sometimes it may lead to amputation of their limb, especially legs. And also, diabetes is a risk factor to developing hypertension. That's high blood pressure. So you can have high blood pressure from hypertension, from diabetes. So there are several complications. These are long-term complications. Obviously, all these things can lead to death, if they're not properly managed. Retinopathy, nephropathy, neuropathy, foot ulcers, even you're more at risk of infections. You develop a lot of infections and all that. You can have a stroke, you can have a heart attack. Diabetes puts you at risk to all these things. So these are the long-term complications of diabetes. So we also have what we call the short-term that can happen suddenly and they can kill. They are called short-term complications. The most important is what we call diabetic ketoacidosis, which is a complication that your blood sugar is so high and you're dehydrated, and then you have symptoms like nausea, vomiting, abdominal pain, altered consciousness, drowsiness, even coma, and you die. So this is called diabetic ketoacidosis. When a diabetic has those symptoms, they will need to be taken to hospital where they will have infusions and insulin treatment. If not, the person risks dying. And this type of complication is common in type 1 diabetes, which I'm going to talk about shortly. There's another complication which is commoner with type 2, though not as often. It's called hyperglycemic hyperosmolar state, which can also lead to coma due to dehydration, and the person may have seizures, drowsiness, and all that. It's not as common as DKA, but it's equally as dangerous. We also have, of course, hypoglycemia, which is a very low blood sugar. When maybe it happens in people who are taking insulin. Sometimes if you take insulin on empty stomach, or you don't have food after that, or you've taken overdose of insulin, your blood sugar just drops. It can drop to the point that you start trembling, sweating. You may even pass out, be going into coma. It can also happen with people who take tablets, certain tablets for diabetes like glycoside. So such tablets, if you don't eat after taking it, you may have hypoglycemia. So these three, DKA, that's diabetic ketoacidosis, hyperglycemic hyperosmolar coma state, and hypoglycemia are three short-term complications, and if they are not properly managed, they can lead to sudden death. Okay, so we've talked about the symptoms, we've talked about the complications, we've talked about what diabetes is. So the next thing to talk about now are what are the types of diabetes, classes of diabetes. So even though there are more than three types of diabetes, the three predominant classes of diabetes to discuss are, number one, type 1 diabetes mellitus, which they used to call insulin-dependent diabetes mellitus, or juvenile onset diabetes mellitus. That's what it used to be called. Then there's another type called type 2 diabetes mellitus, which they used to call dependent diabetes mellitus, or maturity onset diabetes mellitus. We also have the one that happens with pregnant women alone, that will be gestational diabetes mellitus. We also have what we call pre-diabetes state, which some people may refer to as borderline. I will discuss it. And then we have other type of diabetes. We have the one we call MODY. We have the one we call LADA. And there are some that are caused by medications or infections or some other hormonal conditions. But the predominant diabetes are basically type 1, type 2, and gestational. So I will start with type 1. Type 1, which used to be called juvenile onset, means it normally starts in children from day 1 till up to 30 years. But it has been found that it also can start in older people over 35, 40. You can develop insulin, this type 1. But it usually occurs in children, younger people, less than 30 years. That's when it starts. And it normally starts quite quickly. The symptoms show rapidly. And it's normally due to destruction of those cells in the pancreas that produce insulin by antibodies. Your body, they are called autoimmune diabetes, because for unknown reasons, maybe it's a viral issue, a nutritional issue, your body develops antibodies that go to destroy those beta cells in your pancreas that normally produces your insulin. So because of this destruction, your pancreas is no longer able to produce insulin, or they just produce little insulin. So this type of diabetic patients must be on insulin for life because their body is not producing any insulin. Except there's something we call honeymoon. They have what we call honeymoon stage. After diagnosis, their blood sugar returns to normal. And if you do test, their blood sugar is normal. So it might last for months and months. That's called honeymoon stage. But after that honeymoon stage, their blood sugar goes back to being abnormal, and they have to be on insulin, without which they may have the complications of diabetic ketoacidosis that could kill. So this is type 1. The symptoms of diabetes is the same irrespective of type, whether it's type 1 or type 2 or gestational. They are all the same. So type 1 is usually occurs in younger people. That's why it used to be called juvenile onset. But because it has been found that older people also now suffer it, it is no longer called juvenile onset. It's now called type 1 diabetes mellitus. And the differentiating factor there is that there's an autoimmunity, there's an immunological destruction of your beta cells in your pancreas. So what it means then is that because these cells are destroyed, enough insulin is not being produced, and then what happens is sugar accumulates, and then if there's no insulin to take the blood sugar into the cells, it accumulates. So when it accumulates, you have what we call hyperglycemia, and that leads to the symptoms of diabetes. And if it's not regulated or controlled, the person may develop the complications. So that's what happens in type 1. Because the cells that produce the insulin have been destroyed, they are not able to produce insulin. And without insulin in your blood system, if you take any food, any carbohydrate, your blood sugar would rise. And because the body is not able to use the blood sugar without the insulin, your blood sugar level goes up, and you have hyperglycemia. And with that hyperglycemia, you have those symptoms of passing urine a lot, feeling thirsty, and all that. And if it's not treated over a long time, you may develop these complications like that could kill, that I've talked about before. And type 1 is about 10% of all cases of diabetes. And even though I cannot say that it's hereditary, but there's some genetic predisposition in type 1. So that's type 1. Then there's type 2, which constitute about 80 to 90% of all cases of diabetes. It used to be referred to as adult onset diabetes mellitus because it was believed that it only happens in adults. But we have now found that you can also have it in children, especially obese children. So a child can have type 2, unlike we expect, which is type 1. I will explain. So type 2 is the commoner one that most adults have, especially people from 40 and above, but you can have it also in children who are obese. It normally starts, you may have type 2 without symptoms, but after a while, you start developing the symptom gradually. It may take years even of your developing the disease to when you start having the symptoms. So it's a slower onset disease, unlike type 1 that is rapid. So you have the same symptoms as in type 1, but the problem here now is your pancreas has not been destroyed. Your pancreas is still producing insulin, but it may not be producing enough. So because it's not producing enough, or is even producing enough or more, but your system or your body is resistant to the insulin, that insulin is not even working. So you might have insulin, if you check your blood level, insulin is there, but it's not helping the blood sugar to go into the cells. So your blood levels accumulate as well, and you have those symptoms of diabetes that if they're not controlled, you may develop complications, both short term, which is in type 2 is hyperosmolar, hyperglycemic, hyperosmolar state, or may develop the long-term complications like I've discussed before. So this is what happens in type 2. The beta cells are spared, they're not destroyed, but for one reason or the other, you're not producing, your body is not producing enough insulin, or the insulin that is being produced is not, the body is not responding to it. There's resistance to them. So your blood sugar accumulates. Remember, you need insulin to move your sugar out of your blood into your cells for you to do the work of energy production, and also to move the excess into the liver. So without insulin, your glucose level accumulates, and you have high blood sugar, which we call hyperglycemia, and this leads to all those symptoms that I've mentioned. So that's type 2. It's commoner in obese people. It's commoner in people who don't do exercise. It's commoner in people who eat unhealthily. Take a lot of sugary drinks, a lot of poor fatty diet. So people who don't eat healthily. It's commoner in people that drink a lot of alcohol and people that smoke. So this is type 2. Then we have gestational diabetes. Gestational shows that it's diabetes when you're pregnant. So what it means is that the woman wasn't diabetic before she became pregnant. And for whatever reasons, during pregnancy, they develop diabetes. This gestational diabetes is pretty like type 2, but only that it happens in pregnant women. And usually, after delivery, the diabetes may improve or may even resolve. The problem is that gestational diabetes puts you at risk of developing full-blown type 2 diabetes in future. It is a pretty serious condition that if you're diabetic, if you have gestational diabetes, it could affect you and your baby. Some of the problems your baby can have if you have gestational diabetes is what we call microsomia, very big baby that's difficult to deliver. You can have polyhydramnios, a lot of liquor. The baby may have a lot of congenital heart and skeletal abnormalities, failure to thrive. The baby may even, die. The woman may also have there's a high rate of prenatal mortality with gestational diabetes. So this is gestational diabetes, and happens in pregnant women. It may improve or disappear after you've had a baby, but it may put you at risk to developing diabetes, full-blown diabetes in future. And the women who are at risk to developing gestational diabetes are the ones that are obese, the ones that are probably over 35 years, the ones that have a family history of diabetes, or the ones that suffer from a disease we call polycystic ovarian disease or Stenleventhal disease. Is kind of ovarian cyst disease. So if you do suffer that, you are at risk of developing gestational diabetes. So these are then, apart from these major classes of diabetes, which I've mentioned, type 1, type 2, gestational diabetes, we also have what we call maturity onset diabetes of the young, MODY. We have another one we call LADA, which is latent autoimmune diabetes of the adult. We also have diabetes caused by taking medications like glucocorticoids, like prednisolone, dexamethasone. You have diabetes caused by infections like cytomegalovirus viral infection. You also have people that develop diabetes because they have problem with their growth hormone. They have problem with their cortisol. Maybe they have acromegaly. Some people develop diabetes because they also have problem with their thyroid, whether it's hypothyroidism or hyperthyroidism. So we have all these smaller variants of diabetes as well, but the predominant diabetes are those type 1, type 2, and gestational. And type 2 is the main bulk of diabetes, which constitutes about 80% to even 90% of all cases of diabetes. So these are the types of diabetes. So the next question is that, apart from the symptoms, how do you diagnose diabetes? How do you diagnose diabetes? If you do have those symptoms that I mentioned, polyuria, polydipsia, polyphagia, blood vision, weight loss, and all that, you want to check whether you've got diabetes. There are 4 types of blood tests that can be done. I will explain them one after the other. There's one we call fasting blood sugar. Everybody will probably know about that. That one, you will need to fast for about 8 to 10 hours before your blood is taken and checked for blood sugar or blood glucose. So normally we expect that your blood glucose would be less than 6.1 if you did a fasting. So I will talk about pre-diabetes in a minute. So this fasting blood sugar. So if I use the UK unit millimole per mole. So if your fasting blood sugar is more than 7, or from 7 and above, and you've done it twice, one today, one another day, and then that's diagnostic of diabetes. But if you have the symptoms, and then your blood sugar test is done, fasting blood sugar test is done, and it's more than 7, it could be diagnosed as diabetes. There's another one we call random blood sugar, which in which case that person has not fasted, so they just ate food and then you took their blood randomly. Usually after 2 hours of eating, you don't expect their blood sugar to be more than 11.1. Yeah. So if you do that and the blood sugar level is more than 7.8 to 11.1, then you'll be worried. And if it's more than 11.1, then that could be diagnostic, but you have to do it more than once. And if it's that high, then it will be diagnostic. There's another one we call oral glucose tolerance test, which we normally do. We use it to diagnose gestational diabetes these days, or diabetic in very elderly people, especially elderly people who their fasting blood sugar is normal, but they're having symptoms. So these people, what we do normally is they fast, you take their blood sugar, and then after taking their blood sugar, they will drink up to 75 grams of glucose drink, and then after 2 hours, you take their blood again and check their blood sugar level and see how much it's risen. So if it rises above 11.1 or something, or 11.2, then it's diagnostic of those diabetes. And then there's indeed another one, very important one, we call glycosylated hemoglobin, which in short, we call it HbA1c. Normally, in one of my previous talks, I talked about hemoglobin. Hemoglobin is that protein in the red blood cells that carry oxygen. So in situations of diabetes where the blood sugar is so high, those red blood cells get glucose get deposited on the red blood cells, forming what we call glycosylated hemoglobin. So if you check the level of that HbA1c, it can give you an idea of your blood sugar level for 2 to 3 months. Unlike fasting and random blood sugar and oral glucose tolerance tests that are telling you about your state now. But HbA1c will tell you how your blood sugar has been for the past 2 and 3 months. So it's important in diagnosis and it's important in the management of the disease. It gives you an idea of if you're about developing complications. So HbA1c is very important. There are also people that, for some reasons, maybe they're sicklers or something, they cannot do HbA1c. They can have another test called fructosamine. I don't know whether it's readily available in Nigeria, but the gold standard is HbA1c. So the diagnosis, to make a diagnosis of diabetes, is either through fasting blood sugar, random blood sugar, oral glucose tolerance test, HbA1c, or fructosamine. That brings me to another class of diabetes we refer to as pre-diabetes, before diabetes. So some people may say it's borderline diabetes. One of them is called impaired fasting glucose. That if you have pre-diabetes, your level of sugar is not enough to be diagnosed diabetes, and it's also too high to be said to be normal. So it's not normal, it's not high enough to be diagnosed. So impaired fasting glucose is your blood sugar level between 6.1 and 6.9. That's pre-diabetes. It can put you at risk of developing diabetes in future. When I talk about treatment, I'll discuss it. There's another pre-diabetic state we call impaired glucose tolerance, which is after eating or after taking that sugar in oral glucose tolerance test, your blood sugar level that after the test does not the level is not high enough is to be diagnosed as diabetes. Is not more than 11.2 or whatever, and is not lower than 7.8. So that between 7.8 and 11 is impaired impaired glucose tolerance. It puts you at risk of developing diabetes. So it's called pre-diabetes, before diabetes. So is a very important condition that if it's not managed properly, you may develop diabetes. So this is how to diagnose diabetes. So let me see whether there's something else I need to talk about before treatment. Okay, let me talk about prevention. I'll talk about prevention first. Type 1 diabetes does not have prevention. Type 1 diabetes does not have prevention. Type 1 diabetes that I discussed before is the diabetes that used to be called juvenile onset diabetes or insulin-dependent diabetes, which normally happens in children, so there's no prevention. There's nothing you can do to prevent it. It happens, it's what it is. It is what it is. But type 2 diabetes and gestational diabetes, can be prevented. How do you prevent diabetes, type 2 diabetes? Eating healthily, exercising every day. If you're obese, you lose weight, stop smoking, reduce alcohol. These are things you can do to prevent developing this diabetes. There's no medication to take. All you need to do is lifestyle modification, as in, what kind of food you eat. Eat more of less of carbohydrates. I'm not saying don't eat at all, less of carbohydrate, enough protein, eat, nuts, fiber, And then before I forget, because some people are asking, type 2 diabetes can run in a family. It can be hereditary. Type 2 is more hereditary than type 1. Gestational diabetes can also be hereditary. People that have other autoimmune diseases, maybe thyroid, are liable to, they can pass type 1 diabetes to their children. So that's how to prevent diabetes. So let me see before I talk about that treatment, whether there's any topic I have not. I've talked about symptoms. I've explained what diabetes is. I've talked about complications. I've talked about types of diabetes, and I've talked about pre-diabetes. I've talked about diagnosis and prevention. Then, yes. So let me just reiterate diabetic emergencies that can kill you, the sufferer, immediately. There are 3 of them. The first one I mentioned is diabetic ketoacidosis, and this happens mostly in patients suffering from type 1, which are usually young people. But like I said, it's not only young people that suffer it, but usually young people. Adults also suffer it. So the patient has very high blood sugar, have ketones in their blood, have ketones in their urine. Their breath is smelling like nail varnish remover. They have nausea, vomiting, abdominal pain. Some have abdominal pains, some become drowsy and then eventually go into coma and then could die. And to treat it, they need to be rushed to hospital to have infusions and insulin injections quickly. And then it could be cured. It is 100% curable, but time is of the essence. So that's one of the very important medical emergencies that can happen from diabetes. So the other one is what we call hyperglycemic hyperosmolar state. Normally happens with the type 2 but it's very rare. It's very rare. It is normally due to dehydration, and their blood sugar is so high that they become drowsy. Sometimes they have seizures, alter them, they're confused, and then all that. So that's that hyperosmolar state. Then obviously I talked about hypoglycemia, which is low blood sugar, which can happen if you took too much insulin, or you took insulin on empty stomach, or you're taking tablets like glucoside that can cause it for diabetes. So these are the medical emergencies that can kill a diabetic suddenly. So that's why if you're type 1, you're more liable to have hypoglycemia. So we tend to ask them to keep sugary drinks or sugary paste, and then we keep glucagon injection around in case if they're hypoglycemic. We give them a jab if they're unconscious. But if they are conscious, you ask them to take maybe Lucozade or some glucose drink, and they spring back to life. So, let's talk about very important. Very important. How do you treat diabetes? The treatment of diabetes depends on the type of diabetes you're suffering from. So it is important to differentiate between type 1 and type 2. So how do you differentiate between type 1 and type 2? Before, it was taken that any child who developed diabetes suddenly is type 1, while an obese elderly person who developed diabetes is type 2. But now you have to do antibody tests, immunological tests, to differentiate between who has type 1 and type 2, because the treatment is dependent on which type. So you can't just assume and start saying, oh, you're diabetic, come and take insulin, take this, take that. No. So if you're type 1, where your pancreas is no longer able to produce insulin, except when you're on the honeymoon stage, you must go on insulin. So you must be on insulin for the rest of your life. There is no cure. There is no cure, but obviously it can be controlled and you can live as long as possible. So we have different types of insulin: short-term, short-acting, long-acting, intermediate-acting. Some we have now in pens that are user-friendly. So if you're type 1, your doctor will put you on insulin. Usually, most likely you're going to be on 2, the quick acting or short acting and the long acting. So you might find yourself being on Novorapid, for example, or on Lantus. So that one is straightforward. That's straightforward. But the one that's a little bit complicated is type 2. If your symptoms are mild, if your symptoms are mild, your doctor may wish to treat you by advising on lifestyle modification, which we describe roughly as diet controlled. So you might have to meet a dietitian, a nutritionist who will plan your diet, and then they'll ask you to exercise. If you're obese, they'll ask you to lose weight, smoking, reduce alcohol. And then as you're doing this, they're checking from time to time. We'll do your HbA1c, which gives an idea. HbA1c, like I said before, is glycosylated hemoglobin. So that gives an idea, of your blood sugar level in the last 2 to 3 months. So when you're under this treatment, after 2 months, your HbA1c will be checked. There's a target, maybe about 54%. There is a target set for you. So we see that still within target. But if it's creeping up, if your HbA1c keeps creeping up and keeps creeping up, your doctor will tell you this is no longer working. Then you would have to go on oral treatment, tablets. You will have to go on tablets. So, and there are different anti-diabetic medication, but the first line that everybody should be put on unless they have contraindications to it is metformin. So everybody that is diabetic and is diagnosed diabetic type 2, unless they are allergic to metformin or they do have contraindications to using it, the first line is metformin. It's also sold as glucophage. So this is what everybody who is type 2 must be on. We started on. So the way we start is that we normally start maybe 500 milligram twice a day. We test it to make sure you're not having side effects. We increase and increase. We'll be aiming that you should be on 2 grams a day. But some people are on 3 grams. So as you're on this metformin, we'll also be checking your HbA1c, whether your blood sugar level is under control or not. So if your blood sugar level is under control, you will be on metformin alone. And we'll be checking. You'll be on metformin alone. And it's fine. So what we need to do is that every 3 months, we check your HbA1c and it's fine. If it's fine, no problem. You keep taking your metformin, and this metformin doesn't cause hypoglycemia, So you keep taking it. Every year you go to your doctor, you have your eyes checked, you have your legs checked, you have your blood pressure checked, and all that. And if everything is fine, you continue taking only metformin. But if this metformin is not controlling your blood sugar, what we call glycemic control, based on your HbA1c. If the HbA1c keeps going up 50, 60, 65, no. So your doctor would advise that you will need to be put on additional diabetic medication. So you might decide to put you on something we call like glycoside, glibenclamide, So you will now be on 2. So the doctor may want to start the second one on a low dose and keep titrating until it gets to the maximum of, if it's something like glycoside, you may want to be on 160 milligram twice a day. So what it means is that you're on 2 grams of metformin and also on 160 milligram twice a day of glycoside. And while you're on this treatment, your doctor will also be checking your HbA1c every 2 to 3 months. Because it's HbA1c that you would have to use to know whether your medication is working. There's no other way. You cannot be checking your blood sugar every day. No, you just, especially when you're in your type 2, it's only type 1 that you need to take your blood sugar every day because the dose of insulin is dependent on what your blood sugar is, especially the short-acting one. So this, But if you're type 2, you don't need to check your blood sugar every day. So when you're on these 2 medications, your doctor would check your HbA1c, and if it's normal, maybe 54, 58, 60, your doctor will say, stay on them. So while you're on them, you'll be advising you to eat healthily, do exercise, lose weight, and then treatment will be going. You'll be having your regular eye checks every year, your food checks, your blood pressure checks, everything. But if these 2 medications still do not keep your HbA1c under the normal range, your doctor would add a third anti-diabetic medication, oral hypoglycemic. It may be sitagliptin or any other anti-diabetic from a different family. Because all these medications will have to come from a different family. So you're not going to take 2 from the same family. One from this family, biguanide, sulfonylurea, like that. Different families. So you'll be on 3. So while you're on 3, your doctor is also doing the same thing. Checking your HbA1c to see whether these 3 are doing the job. Because this HbA1c will tell us whether you're winning. So as you take the 3, every 2 to 3 months, you have your HbA1c checked. You must have it checked. And then if it's normal, you can continue on this 3. But in certain circumstances, and in a lot of circumstances, your HbA1c keeps going up, despite the fact that you are on maximum dosages of these 3, and you're taking your medication regularly, and you're eating healthily, you're doing exercise. So if you're on 3 medications, even though you're type 2, your doctor will start considering to put you on insulin. That insulin that type 1 takes forever, at that point in time, your doctor may suggest to you that you may need to go on insulin or other injectable treatment instead of the tablets. I've seen where because obviously being on insulin has got a lot of implications with driving. You have to, if you live in an advanced world and you're on hypoglycemic, you're on insulin, because it can cause hypoglycemia, it impacts your driving. So your licensing authority will have to know. They will tell you how to drive, where to drive, and when to drive, and how long you can drive, and you have to stop at certain implications. So some people do not, and also the fact that you'll be injecting yourself every day, So some people will not want to go on that insulin, so they want to delay it. So such people that want to delay it may go on 4 diabetic medication from 4 different families. So if you go on it, the usual process continues. Your HbA1c is checked and all that. If those 4 do the job, then fine. If it doesn't do the job, then your doctor would be serious about it, that this is not the time to go on insulin. Because the higher your HbA1c, the more likely you could develop complications like kidney problem, blindness, neuropathy, all those, stroke, heart attack. So the HbA1c is a predictor of all those complications. So the higher it creeps up, the more your chances of becoming very unwell or dying. So that's why your doctor will not say, at this point in time, the medications have not done the job, so you have to go on insulin. So sometimes when you start insulin, you may be on tablet, maybe 1 tablet and insulin together, or you may go off tablets completely and be on 2 insulin. You'll be on long-term insulin, which is the basal insulin, and if your blood sugar goes so high, you may also be on short-term insulin and all that. So while you are taking this treatment, the guidance we have is, if you're diabetic, your blood pressure will have to be monitored, because if you're diabetic and you're hypertensive, you stand your risk of having cardiovascular events like stroke and heart attack is higher. So your blood pressure will be checked often, and what is normal blood pressure in normal people is not the same thing as what is normal blood pressure in a diabetic. In some centers, they want your blood pressure to be 130/70. If you're diabetic, you need to, get it down, if it's high. So some centers allow 140/90, but anything more than 140, you need to be on treatment. Then there's another medication that is important in diabetics. We call them statins, like atorvastatin, pravastatin, simvastatin. They are cholesterol or lipid lowering medication. The advice is that if you are 40 years and above and you're diabetic, full-blown diabetic, especially type 2, whether your cholesterol is high or not, you will need to be on cholesterol lowering medication for the rest of your life. So if you're suffering from type 2, apart from your diabetic medication and you're above 40, you would have to be on statin. And if your blood pressure is a little bit high, you may need to be on blood pressure medication as well. If you're less than 40 and you have risk factors to having heart attack, you would also go on cholesterol. And there's a way a cholesterol lowering medication, which we call statins. Another medication that people take that you want to know is aspirin. Does every diabetic need to be on aspirin? No. You only go on aspirin if you have risk factors to having these coronary heart coronary events, then you can be on aspirin. But otherwise, if you don't have those risk factors, you don't need to be on aspirin. So this is the way diabetes is managed. There is no cure for diabetes. If you're diabetic, it is going to be lifelong. And if you are suffering from, if you've been diagnosed with pre-diabetes, meaning that your blood sugar level is usually, is not high enough to be a full-blown diabetic and is not low enough to be normal, do you go home and fold your arms and wait for it to blossom into full-blown diabetes? No. We advise dietary modifications, healthy eating, exercise, and in some circumstances you may go on medication. So the essence of taking this medication is not that you are diabetic already, but it's because this pre-diabetes puts you at risk. Diabetes. So the earlier you started taking the medication, the better for you, because it would prevent you from moving from that stage of pre-diabetes to full-blown diabetes. So that's what happens with pre-diabetes. Obviously, I think I have exhausted what I want to say. So I've talked about, let me just look at my headings to see whether I forgot anything. Because when you say these things from your head, so I've discussed what is diabetes, what condition it is, talked about insulin, how insulin is produced, what causes the deficiency, and if insulin is not produced, how sugar rises in the blood, and the function of, So I've discussed that. I've discussed the symptoms of diabetes. I've discussed the short-term complications and long-term complications. And also, diabetes puts you at risk to developing a form of dementia. So it's also one of the complications. I forgot to say it. It's called, I think, the multi-infarct dementia. So I've also discussed the types of diabetes, type 1, type 2, gestational diabetes mellitus. I also mentioned other variants like maturity onset diabetes of the young. I also mentioned latent autoimmune diabetes of the adult, LEDA. I also discussed diabetes that can be caused by medications you take like prednisolone, dexamethasone, even beta blockers like atenolol. Propranolol can put you at risk to developing diabetes. I also talked about disease conditions like cytomegalovirus can cause, and things like hormonal problems, acromegaly, hypothyroidism, hypothyroidism, all those things can lead to diabetes. I've mentioned that. And I also talked about prediabetes, which is like harbinger to developing diabetes, impaired fasting glucose, and impaired glucose tolerance. These are conditions where you are not a diabetic yet, but your blood sugar level is not normal. So it's like borderline, but it still needs to be taken care of, because if you do nothing, you may well progress from this stage to full-blown diabetes. I also obviously talked about gestational diabetes that happens in pregnant women, especially those that are above 35, those that are overweight, those that have a family history of diabetes, and those that suffer from polycystic ovarian disease. Those diseases where some women are stocky and they have hair, and they have problem with ovulation. That's polycystic ovarian disease. It puts you at risk to developing gestational diabetes. And like I said, gestational diabetes may improve or resolve after childbirth, but it may also put you at risk to developing full-blown type 2 in future. So I also talked about, what else did I talk about? I talked about how to diagnose diabetes. I mentioned the fasting blood sugar, random blood sugar, oral glucose tolerance test, and I mentioned glycosylated hemoglobin and fructosamine. I explained them and how they work and how they're done, and then I discuss obviously the levels for diagnosis. And then what else did I talk about? I've talked about, yes, I also forgot that if you're diabetic, especially in the advanced world, you need immunization, flu jab every year, pneumovax, things like that, because you're liable to developing infections from time to time. And I talked about diabetic emergencies, especially diabetic ketoacidosis, hypoglycemic hyperosmolar state, and then hypoglycemia. I talked about how to prevent diabetes. I mentioned that type 1 does not have any prevention, while type 2 can be prevented if you live healthily, if you lose weight, if you stop smoking, if you stop drinking, if you do exercise, if you eat properly. Things like that can help you reduce your risk of developing diabetes. I also talked about complications of diabetes. I'm only recapping. I talked about the complications, which include the effect on the eyes, glaucoma, cataract. Glaucoma is increase in pressure in your eyes. Cataract is that covers your eyes that you won't see when you have them, that can be removed by operation. I also talked about the main complication, which we call diabetic retinopathy, where you have bleeding in your eyes and changes in your eye that, if you do the camera, if you go and have it snapped, photographed once a year, you can detect if you have a problem. And if you do have a problem, it can be cured. But if you don't do it, you are liable to risk, you're risking blindness. Then nephropathy, which is kidney problem, that if it's not controlled can lead to kidney failure and death, obviously. And then we talked about neuropathy, where you lose sensation in your leg and your hand, and then you sometimes you walk as if you're walking on a foam, and then you can't, even if you pinch your leg, you won't feel a thing. So when you have that problem, if you have a sore on your legs, you may not even know that you have a problem, and that can lead to a sore that is not healing. That's why if you're diabetic, your foot care is important. You have to wear good shoes that fit well, and make sure you don't have injuries, because if you have injuries, you have to make sure that they are healed, because if they don't heal, then they may turn into a chronic ulcer. Chronic is the ulcer that is not healing, and then if the ulcer compromises, if there's compromise in the blood supplies to your foot, you may lose that foot, and then it leads to amputation. That's why you see some diabetic in wheelchairs or in crutches, is because of those ulcers. So foot care is very, very important in every diabetic, be it type 1 or type 2. So I talked about the treatment. Type 1, everybody that suffers from type 1 must be on insulin for the rest of their life. Type 2, the treatment starts by lifestyle modification, which is like diet, eat healthily, lose weight, and things like that. And if that is not doing the job, then you would have to go on tablets, and you start with metformin, go up like that to 3 different let me see whether there's any question. So far, I haven't seen any question. Please, you're fast. Was I fast? I don't think I was fast. If you can go back and read it, darling. See grammar. I thought I explained them. Two people have complained that I was a bit fast. I don't know how slow I could be. Unless I have to be biting my tongue. I haven't seen any questions, to be honest. Oh, God. So somebody asked me, what are the signs of the eye complications? I explained, if you do have retinopathy, you will not know unless you went for the photography of your eye. Then they'll see that there's leakages and there are exudates in the back of your eye, and these are the things that can lead to blindness. Obviously, it can affect your vision. You probably won't see as well as you used to. Then if you do have glaucoma, which is increased pressure in the eye, your vision will be affected. You may have pain in your eye, headaches. If it's cataract, you see it is like a coating over your eye. I don't know how to. So these are the things you can have. Does diabetes have anything to do with hypertension? I said that diabetes puts you at risk to developing hypertension. Aside excess sugar, what else causes diabetes? Nothing. I didn't say excess sugar actually causes diabetes. Diabetes is due to the symptoms of diabetes is due to excess sugar, but sugar does not cause diabetes in itself. But obviously, if you have risk of diabetes, if you take a lot of simple sugars, it puts you at risk. But I explained several times that are things that put you at risk to developing diabetes. If you join in late, I will save this, and then you can go back. Can it be cured? Nope. Diabetes is not curable. DKA, I've done so. Yeah. Is diabetes hereditary? Especially type 2. Type 2 can run in a family. Type 1, yes, you can, but type 2 has more of a hereditary factor. Wisdom, you're studying medicine. I know. If you're paying attention, you study medicine. You will know, at least you can treat some of these conditions. So, somebody's telling me that Obesek is winning in Edo State. I sold many meat pie today. It didn't concern me. Waiting concern and overload. Where is Uma is watching? Where is she watching from? Do you see her? Uma is watching. Can diabetes sore be managed? I mean, yeah, of course. Without amputation, you only amputate when the blood supply to the limb is compromised. Before then, you can keep dressing it and putting whatever you need to do to help it heal and controlling blood sugar. That is easier. We're not in America. I don't get that. Type 1 diabetes has no prevention. Yes, I said so. So maybe I'll look at see whether there are questions later, because I have to go now. Peeing in drops in a man, any sign? No. Those that pee in drops, peeing as if there's blockage, there may be prostatic hypertrophy or hyperplasia. Maybe they have problem with the prostate, or they have a stricture, which is like narrowing of the tube. This has nothing to do with diabetes. Nigerians don't like. Okay.